Let us take a model. Because otherwise, I have to again and again go take the model and come back. So we'll first start the anatomy, then we'll go to the fluid anatomy, and last but not the least is the MRI interpretation. So, how is a cervical vertebra is composed of? Remember, cervical spine is having mainly composed of 7 different vertebra. So that starts from the one, that is the C1, C2, C3, C4, C5, C6, and C7. But there are altogether 8 nerves. So from above the C1 starts the C1 nerve, C1 cervical nerve, whereas just below the C7 we have the C7 cervical nerve. So there are the vertebral bodies, there are the transverse processes, there we have the these articular pillars, we have the lamina, we have the spine, so everything that we see is there. So let us see that 7 vertebrae C1 to C7. It supports the head and protects the spinal cord and provides mobility to the neck and hip movements as well. And being a mobile region, remember, like the lumbar area also is a mobile region. So whenever it's being a lumbar mobile region, so they are prone to injuries and degenerative changes. So that happens for the cervical spine as well. Now, there are some unique features in the cervical spine. So, what are those? First of all, if you look at the cervical spine, especially if you look at the foramens in the transverse processes. Remember, in all other area of the spine, you will not find a foramen within the transverse process, but in cervical vertebra, there are foramens in the all cervical vertebra. So basically, these foramens are known as the foramen transversarium. This foramen is for the passage of the vertebral artery from both the sides to the brain. Then comes to the spinous process. Apart from the C7, which is the largest cervical vertebra and which is also an atypical vertebra, all the typical vertebral vertebrae, including C2, remember C2, C1, and C7, all three are the atypical vertebrae. Among those vertebrae, excepting the C1 and C7, so all the vertebrae, spinous processes are bifid, among which the nature of the bifid varies. In C2, it is an inverted V2 type, whereas in case of others, they are totally bifid spinous processes. So that is also a difference with the rest of the spinal cord, not the spinal cord, spine. But there is another difference also in the vertebral body. So if you look at from the anterior side, let me open my image because otherwise I am not able to see. If you look at from the anterior side, what we'll see, there are some projections in the lateral part of the vertebral body. So if you look at carefully, so there are some projections in the lateral part of the vertebral body. So these are these small projections in the lateral part. I think you can see it, but there is a little bit of portrait lighting is on. Let me switch off that, otherwise it will be a little bit difficult for you. So portrait lighting switch off, okay? Otherwise it is not seen properly. So if you look at like this, so you will be able to see that in the vertebra, okay, by the just by the sides, you can see these are the projections are leaping in both sides of the cervical vertebral body. And this is known as the process, and this is known as the uncinate process. So what uncinate process do? They actually makes the cervical vertebra more stable by reducing the sidewise movement of the one vertebra over the other. So that is also important, and they forms the ancovertebral joint. So pathologies like ancovertebral osteophyte has the remain very close to the foramen. So if you look at here, this is the ancovertebral joint and here is the foramen. So as they are very close to the foramen, so if there is an ancovertebral joint arthritis or there is some pathologies like an osteophyte, so they can compress on the nerve and that can give rise to a feature like radiculopathy. So these are one of the changes that we see in the cervical vertebra if you compare, which is different from the other vertebra. Just one second.
Sir, that spine model is not so much visible.
Yes, I know spinal model is not so much visible, but here that's why I have reduced that. Now I think you can see it.
Still
So, no,
small.
you just increase the size. Okay.
Okay,
So
sir.
what you can do, you can increase the size. So that is the way.
Mm,
Okay. So what I
yes.
have shown, just look at this part because it is a little bit difficult for me to focus from the opposite side. So if we look at this part, okay. So here are the oncovertebral joints. So these are the unseen processes. So it has a lot of importance, especially when we'll be learning the fluoroscopy guided interventions. For example, fluoroscopy guided DRG injection or fluoroscopy guided stellate ganglion block. We have to follow this unseen process. So that is why it is very important. And to look at under fluoroscopy, you have to look it in a view where it is an oblique and slightly inferior angle. So that we will learn with time. Okay, let's move to the next slide. Now coming to the atypical cervical vertebrae. So what are the atypical cervical vertebrae? I have already told it is a C1, C2 and C7. So what is the atypicality of C1? Everything is atypical. Neither it has a body nor it has a spinous process. In both the sides it is a tubercle. Then there is also a facet in the anterior part. There is a transverse ligament and through which the dens or the odontoid process of the C2 that enters. So this is the C1. It has no body. It articulates with the skull in one side, that is articulating with the occipital bone of the skull, and also it is having this space for this odontoid process and also this transverse ligament for the C2 to attach here. Whereas in C2, as I told, it is having a bifid transverse process. And in fact, from above, if you look at C2 is the first bifid transverse process, so spinous process that we see. And also in the anterior side, we can see the dens or the odontoid process that joins with the axis. And clinical relevance, you all know if there is a break at this area, it's a life-threatening condition because it can actually compress over the spinal cord or the medulla oblongata. At this point, spinal cord is not there. So what we are having is the medulla oblongata. So that could be dangerous. Now coming to the supporting ligaments. There are multiple ligaments around the cervical spine supporting the cervical spine that includes the transverse ligament that I have already told. There are alar ligaments which limit the rotation. There are ligamentum nuchae that supports the head posture, and this ligaments injuries can cause instability. And last week we have discussed about the acceleration deceleration injury. So in acceleration deceleration injury, sometimes there could be injury to the ligaments and also that can lead to instability, and that can also lead to another condition that is a facet arthropathy. So all are possible. Let's move to the next slide. Coming to the facet joints. Like the lumbar or the thoracic area, in cervical spine, there are facet joints. So what are the facet joints? Facet joints are the paired joints at the back of the spine. It's there in the whole spine and its role is to stabilize the vertebral body. Remember, they are the small synovial joints with capsule, whereas the anterior part of the capsule usually blends with the ligament, which is known as the ligamentum flavum, and also these joints help in a lot. First of all, it helps in movement. It gives the stability because without this, the stability and movement neither would have been possible. So being in the posterior side, it is giving the stability and being in both the sides, it is allowing the cervical spine to bend forward and backward and rotate. Remember, whenever we are putting our head back, it is putting stress over those facet joints. So, being a synovial joint, it is prone to arthritis as well, especially if there is a traumatic cause or sometimes because of the inflammatory cause, for example, in a spondyloarthropathic case. So, these joints can be inflamed and can be a source of pain. So whenever you do some maneuver that is leading to a loading of these facet joints, for example, I am extending my head. So I am actually putting more pressure over my facet joints. When I am rotating my head to the left or right, so I am actually putting stress over these facet joints. And if the facet joints is painful, all these activities could be painful. So that's the important, and we have to know the facet. So remember, facet joint pain is mostly localized pain which remains at the back of the spine, usually paramedial, and it increases with the extension as well as the rotation. And sometimes it might happen in very rare condition. A facet joint can also give a radicular pain when there is a facetal cyst which is coming to the anterior side and compressing over the root, or a facetal hypertrophy compressing over the facet root. These are the conditions where facet joint can give a radicular pain too. Now coming to the cervical musculature. Now it is very important for the cervical spine because to give mobility you need a proper musculature. And these musculatures are important, especially what it does. So it helps in the movement of the neck. And now, nowadays, a number of persons are working from the computer or from home. So what happens? So they are actually using their back muscles too much. So ultimately, that can give rise to the myofascial pain as well, because there is a continuous pulling whenever we are bending forwards. Now, what are the groups of the muscle around it? So, if you look at the anterior side, we have the longus colli, which is very close to the vertebral body and the transverse processes. We have the scalene muscles, just slightly posterior to this longus colli and in the sides also. Then these are important for the flexion and stabilization. In the posterior group of muscles, we have the splenius capitis, which remains like a splint like this. I will show in a while. Then there is a muscle which is known as the semispinalis capitis, which is a long, large muscle at the posterior side, which is a middle group of muscle. Neither it is superficial, not too deep. So this muscle helps in the expansion of the spine. Remember, whenever these muscles are affected, sometimes it can undergo spasm, causing pain, or sometimes can cause weakness, and it can be associated injuries with the whiplash injuries as well. Now, coming to the most superficial muscle at the back. Remember, trapezius is the superficial flat muscle like latissimus dorsi in the lumbar area. At the cervical area, we have the trapezius. So, what the trapezius does? Trapezius is a flat muscle covering all the other muscles underneath. So, it takes origin from the occipital bone. It takes origin from the ligamentum nuchae. It takes origin from the tip of the spinous processes, and it goes up to the T12. And then these fibers actually divide into three groups. The upper group of fibers goes down and anteriorly, and they attach to the outer third of the clavicle, whereas the middle fibers go mostly horizontally and they attach to the acromioclavicular joint, the acromion, and the lateral portion of the spine, whereas the lower fibers they move up and laterally to attach with the posterior part of the spine, posterior medial part of the spine. That is the spine of the scapula. So this is a muscle. Remember, this muscle is prone to the myofascial pain, and in a number of cases, we found commonly this muscle affected by the myofascial trigger points. Now, if we remove this muscle, just underneath, we get the splenius capitis muscle, which takes origin from the spinous process of the C7 to T3 and along with the nuchal ligament, and it's insert to the superolateral nuchal line of the occipital bone and close to the mastoid process of the temporal bone. So it is attaching at this point. Remember, it remains as a splint-like. That is why the name is splenius, and it is one of the superficial group of muscles. Now, if we go slightly deep, we should say middle group, or it's also a part of actually the superficial group only. So it is the semispinalis capitis. So it takes origin from the articular process of the vertebra, that is C4 to C7, and transverse process of the vertebra T1 to T6, and it inserts again to the occipital bone in between the superior and inferior nuchal line. So this semispinalis muscle is important because one nerve which is very important is the greater occipital nerve that winds underneath this muscle and then pierces this muscle, then pierces trapezius, then it becomes superficial, and this is one of the important nerve Sometimes when affected, it can cause pain and which is known as the cervicogenic headache, or whenever it is also affected by the neuralgia, it is known as the occipital neuralgia or greater occipital neuralgia. Let's come to the levator scapulae muscle. Which this muscle takes origin from the transverse process of the vertebra C1 to C4 and attaches with the medial border of the scapula. So if you look at and follow the supraspinatus, slightly middle, we'll be getting this muscle. This muscle is also important because like trapezius, this muscle can also be affected by the myofascial pain, and then it is known as the levator scapulae syndrome. Now coming to the another very important and deep muscle. Remember, those who can remember the anatomy very good, they can remember a triangle which is known as the posterior triangle. Okay. So this triangle, study not the posterior triangle is here. This triangle is known as the, at the back, there is only one triangle which is known as the suboccipital triangle. Suboccipital triangle is a triangular area at the back which is bounded by small four muscles. So what are those muscles? So below and laterally, it is the obliquus capitis inferior, above and medially by the rectus capitis superior major and minor, and above and laterally by the obliquus capitis superior. So remember, this portion is the triangle and it contains suboccipital nerve and the vertebral artery, and one nerve goes through the roof of it, that is the greater occipital nerve. So what does the greater occipital nerve do in relation to the obliquus capitis inferior? Remember, obliquus capitis inferior is a small muscle which takes origin from the spinous process of the C2 and attaches to the transverse process of the C1. So it's a very small muscle, just C2 to C1. But for pain physicians, that's a muscle of advantage because number one, the greater occipital nerve just winds round below this muscle and moves up. So it's a good location to find out the greater occipital nerve under the semispinalis capitis and in between the semispinalis capitis and this obliquus capitis inferior. So what we do, we under ultrasound try to figure out this muscle, that is the obliquus capitis inferior, that can be seen easily with the ultrasound, and then in between these two, that is obliquus capitis inferior and the semispinalis capitis, we inject in this plane, in a plane, so by which we can actually do a hydrodissection for the greater occipital nerve, and that can be useful for the cervicogenic headache and also for the greater occipital neuralgia. So that's why inferior oblique is very important muscle. And remember, it is very easy to find the inferior oblique muscle. So inferior oblique also serves as a target to find out the specific level of the cervical, especially which body has C2. By seeing this muscle, we can find out the spinous process is C2. Now coming to the sternocleidomastoid, definitely one of the big important triangular muscle. Remember, when we say triangular muscle, remember in upper limb, it is the sternocleidomastoid which in throughout its course remains triangular in cross section, and in the lower limb, it is the sartorius that also remains triangular in cross section. It is having two heads, one is the sternal head, one is the clavicular head, and which inserts into the lateral surface of the mastoid process at this point and lateral half of the superior nuchal line of the occipital bone. So this is also very important muscle. Remember, the arch point or the superficial cervical plexus nerves, they go from at this area just behind it, and also sometimes this muscle can undergo myofascial pain as well, and also for the different procedures like a block in the cervical brachial plexus and also in the block for the stellate ganglion, this muscle serves as an important pivot point around which we search the structures. Now the neural networks. Cervical spine surrounded by the rich neural networks. The important nerves are all arising from the spinal cord. So there are C1 to C8 main spinal nerves, which after coming out divides into anterior, posterior and intermediate branches. And the spine itself is supplied by the posterior branches mainly. For example, the facet joints, they are supplied by the medial branches from the posterior side of the same nerve root. So it will be discussing in detail because for managing the cervical spinal pain, we are going to block these nerves. So it is the C1 to CY8. C1 nerve comes above C1 vertebral body and C8 nerve comes up in between the C8 and C7 and T1. So radiculopathy or myelopathy can occur due to the foraminal stenosis or sometimes the disc herniation. This is the greater occipital nerve. As I told, it is a continuation of the posterior ramus of the C2 spinal nerve. Okay, and this actually winds around the inferior oblique muscle and then it moves up, supplies the posterior part of the neck. So, in cases of cervical problem causing headache, this nerve is having a huge importance. Suboccipital nerve, not that important. It is the dorsal ramus of the, it's a very small nerve and it is the dorsal ramus of the first cervical nerve or the C1. Next comes to the third occipital nerve. Remember, it is the continuation of the main trunk of the posterior ramus of the C3. Remember, obviously, it is the third occipital nerve, so it starts from the C3. It moves from above the C2 C3 facet joint and then it continues from the central side and supplies a small area over the back. So, whenever the C2 C3 facet joint is involved, it is commonly causes cervicogenic headache because of such kind of nerve supply. Now we should remember these three important nerves which are supplying the posterior part of the neck and scalp. So what are those? They are the greater, lesser and third occipital nerve. Remember, we discussed about the greater occipital nerve, we discussed about the third occipital nerve, but we have not discussed about the lesser occipital nerve. Because lesser occipital nerve is not a branch from the posterior ramus, rather it is a branch from the anterior ramus. So third occipital nerve, so if we look at one by one, third occipital nerve is the posterior root of the C3. Greater occipital nerve, it is the medial branch of the posterior root of the C2. Whereas the lesser occipital nerve is the ventral ramus of the C2, along with sometimes it receives a fiber from the C3. So that is how we three nerves are supplying. And just anterior to it, there is another branch from the superficial cervical plexus, that is the great auricular nerve, which supplies the posterior part of the ear. So we have understood the important nerves at the back. Now coming to the innervation of the cervical facet joints. Remember, facet joint syndrome is a very common cause of the cervical pain, especially non-dermatomal cervical pain, which is associated with the movement of the spine. If you look at one, I have discussed about the myofascial pain. The other one is definitely the cervical facet arthropathy. So I have already discussed about the acceleration deceleration injury. Definitely, cervical facet arthropathy is one of the common cause of that whiplash associated disorders. So we need to know the exact supply, that is the nerve supply of the cervical spine, especially the facet joints. So, how these joints are supplied? Remember, the first two joints, they neither lie in the same anterior-posterior plane, they are much more anterior, and they are neither supplied by the dorsal ramus. They are supplied by the ventral ramuses. So, in between the joint between the atlas and the occipital bone, okay, that is the atlanto-occipital joint, it is supplied by the anterior rami of the C1 spinal nerve. Whereas the C1, C2, it is supplied by the anterior rami of the C2. Remember, they do not lie in the same plane. So if you look at from the, with the ultrasound, if you look at the first joint, we will be able to see when we are following the cervical facet is the C2 C3 joint, because other two, they are above, they are lying in an anterior plane and also they are supplied by the anterior ramus. And C3, C4 onwards, they follow the same rule. So what is the rule? Like in all area of the spine, they are supplied by the median branches. So the medial branch, basically the first branch is the anterior and posterior ramus. Posterior ramus divided into three. Now the medial branch, they goes posterior. In the lumbar area, they remains at the junction of the superior articular process and the transverse process. At the cervical area, they remains in between the facet joint. So these are the facet joint, this is the facet joint. So this area is in between a facet joint and it goes posteriorly from here and then it divides and supplies First, one branch to the above facet joint, one branch to the facet joint below, and there is another muscular branch which is given to the multifidus muscle. So, for one facet joint, for example, this is the C5, this is the C4, this is the C4 C5 facet joint. It is supplied by a branch from the C4 and it is supplied from the branch from the C5. So in the cervical area, C4 C5 facet joint will be supplied by the branch posterior medial branch of the dorsal rami of the C4 and C5 spinal nerve. So in that way, it is very simple. Okay, so C3, C4 onwards, the fall rule will be same. So we know the location of these joints. Here there is only a difference at the level of the C2, C3 because the median branch is there that is supplying the facet joint there, but the main trunk continuing as a third occipital nerve. Similarly, from the C2, the branch is going above, which is going as a greater occipital nerve. Okay, so that is the difference in the upper area of the cervical spine. Now, previously it was thought that these location of these medial branches are always at the same area, that is in between these two articular pillars. So if you look from the lateral side, even under fluoroscopy, you will be able to see some undulations. So these are the undulations. See, these are the undulations. Okay, undulations. So hill, and valley, hill, valley. And it is considered that the hilltops are the joints and the valley portions are the nerves. Okay, so in that way we used to reach there, and definitely with a little bit stimulation and manipulation we used to find out the nerve. But this is a cadaveric study where they have shown that the exact location which remains at the middle of this articular pillar is the C5. Okay. From C5, if you move up or down, usually the average location of there are multiple points. Okay, you can say. So this average location of medial nerves is slightly above than the midpoint of this area. Okay. So this concept was very, very important, and this study was also very, very important because there we got an idea that from where these nerves are going. But nowadays, as we are using ultrasound, we are directly seeing the nerve. So this is not that important because now we can see the nerve and we can block it after seeing the nerve. Now coming to the arteries and veins. So what are the important arteries? So first I have told the vertebral artery. It's an important artery. It's not only important, the important increases a lot for us because this artery remains in such a crucial point that for certain interventions, this artery, if accidentally punctured and particulate steroid if accidentally inject, it can cause cerebral ischemia and stroke. So we will not be wanting that. Or sometimes, even if it is not given the particulate steroid, you are injuring it. That can also give rise to an arterial spasm. So if the other is working fine, then you are scared, the problem might not happen. But there is a possibility that can go into the cerebral ischemia. So in every cases, we have to be very careful about the location and position of this artery. Remember, with the fluoroscopy only days, when we are not having the ultrasound, we are not able to see this artery. So there are more possibility of accidentally injuring the artery. But nowadays we do under ultrasound guidance and we usually see the artery along its course. And according to the presence of the artery, we sometimes, for example, we are going for a stellate ganglion block, which remains in the junction of the body at transverse process of the C7. And just anterior to the stellate ganglion remains the vertebral artery. So in those cases also, we usually take a path which is not puncturing the vertebral artery, and we can go directly over the longus coli and go underneath the above the fascia covering the longus coli and posterior to the prevertebral fascia, and we can actually inject in a perfect location. So ultrasound has given us advantage, but even though then there was no ultrasound, we have taken a technique by which we can go from the anterior side and we will be going in oblique fashion so that we will come to the base of the articular pillar close to the uncinate process and we will be avoiding the vertebral artery. So there are ways, and there we have to check with the fluoroscopy. In fluoroscopy what we do? We check with the contrast that it is not intravascular, then we do the procedure. So that is the importance of the vertebral artery. Apart from this, there are venous plexuses around it, and also we have the carotid artery in front. Especially if you are doing any procedure from the anterior side, you should be careful about the carotid as well. Now coming to the common pathologies that can affect the cervical spine. Remember, first of all, degenerative disorders, for example, degenerative arthropathy. They can affect the disc. So, early phase, they can cause discogenic pain. In serious of more, when the spectrum increases, it can cause a disc bulge. Then it can cause a disc extrusion. Then it can cause a disc sequestration. So these are all stages of the cervical prolapse and they can cause affect the disc. When it is affecting the cervical facet joints, so it can cause a facet arthropathy. Sometimes if there is a hypertrophy, it can cause a radicular pain. If there is an osteophyte and which is maybe obliterating the foramen, then also it can cause a pain which is a radicular pain. Next comes to the disc herniation. We all know about disc herniation, which is fairly common in the C5, C6 and C6, C7. In fact, most commonly it is the C5, C6 which is affected and which give rise to a radicular pain. Then comes to the whiplash associated disorders that we have discussed in the last day. And today's class is already a little bit large class, so I'm not going into again into the whiplash associated disorders. So these are the common pathologies affecting the cervical spine, which are skeletal pathologies, and always like the myofascial pain, which is the commonest cause, that will remain in these areas as well. Now coming to the next part, the importance of the cervical spine anatomy in practice. Now after all this, because when I have told them anatomy, I discuss about the diseases. So now I think this slide is having not having much value. So remember, accurate diagnosis relies on acute understanding of the anatomy and imaging modalities. Because if you don't know what is the structure, what we will see in X-ray, CT or MRI or USG, so we have to know the anatomy and based on which we will be discussing the rest. That is the fluoroscopy, CT and MRI imaging. Okay. So any questions regarding this anatomical part? Okay. As you don't have any questions, let us do one thing. Let me ask you a few questions. Okay. Okay. So let us open the now. Okay. First, let us start with the body structures. Okay. Then we'll go to the other structures. Okay. So I'm just putting a red dot. Any one of you can tell what is this structure?
Facet.
No, it's not facet.
Transfer process.
Yes, transverse process, but we be particular. I have not touched pointed here because this is the transverse process.
अरे रोहन और टिके
This is the foramen transversarium. Okay, and transverse process has also other two atypicalities that was also I have not discussed are this. Okay, this is one tubercle and this is another tubercle. So the tubercle at the anterior side is known as the anterior tubercle. The tubercle at the posterior side is known as the posterior tubercle. And if we look at, especially at the level of the C6, when we look, you will see the anterior tubercle is much larger compared to the posterior tubercle, and this is known as the Shishagnax tubercle, and this is an important landmark for a multiple procedures like a brachial plexus block or like stellate ganglion block. So it is also having importance because by looking at it, you will be able to locate the anatomy. Now I am drawing two dots. This is one, this is a red dot. Now, which one is the facet joint and which is the location of the medial branch?
Red is the facet joint and blue is the medial branch location.
Perfect, perfect. So red is the facet joint and blue is the location of the medial branches. Okay, so I think the basic you have understood, and a few more questions about the muscles. So let me back to the muscles. So this muscle I am not asking because it is trapezius that we all know. We are hiding it. So just underneath the trapezius, what is this muscle? Let me.
Splenius capitis.
Yes, this is the splenius capitis. So let us clear it and hide it. Sorry. And if you hide the splenius capitis, then what is this muscle?
Semispinalis capitis.
Spinous capitis. And underneath, what is the muscle?
Obliquus.
Obliquus capitis inferior. And this one?
Obliquus capitis superior.
Yes, this is rectus capitis superior major. This is rectus capitis superior minor. Okay. So, okay, you have already grabbed a lot of it. So, I am not going to further discussion. So, because the slide is large and you have to cover everything today. So, we'll take time. So, let's come to the fluoroscopy. Now, fluoroscopy, what it can show bony alignment, it can show bony fracture, it can show bony displacement. So, fluoroscopy has a lot of importance, and fluoroscopy has a lot of importance for us because for a pain physician, fluoroscopy is the basic equipment by which we target and localize the structures, whether it's a soft structure or it is the hard structure. We can see only the hard structure, the bony structure, but based on which we can also target the soft tissue structures according to the location. Now, fluoroanatomy, it offers the real-time visualization of the bony landmarks, essential for the safe and accurate cervical spine interventions, and it reduces complications in procedures like epidural steroid injection, medial band blocks, and all the cervical procedures we do. Now, what are the structures we can see? We can see all the bony structures that I have shown. So it can show the spinous process, the sternal alignment, it can show the vertebral bodies, it can show the ancovertebral joints and everything. So let us see what are the structures we can look at in the AP view. One thing you should remember, in the cervical spine, usually the outermost structures that we see, so it is the outermost structure that we see in the bony tissue, it is not the vertebral body. In all other areas of the vertebral areas, those spinous process, transverse process projects, but if you see a continuous line in the lateral part, they are the vertebral bodies. But at the cervical area, the vertebrae bodies are smaller. They are only from this area to this area, from this area to this area. Okay, they do not go till this area. So this area is having from the posterior side only the articular pillars. From the anterior side, it has the transverse processes. It has the foramen transversarium through which the vertebral artery go and also the nerve roots come out like this. Okay, so it has a lot of importance. So if you look at this area from the anterior side, this area is a very sensitive area. This area is a very sensitive area. But from posterior side, you are safe because either you will be hitting the lamina or you will be hitting the posterior part of the articular pillar or it will be going to the ligamentum flavum. Okay, the ligamentum flavum is the only risky part. For other areas, it is comparatively safe. Now you see these projections, so small projections. So what are these? What are these?
Uncus.
It is the uncinate process. Okay, so this is the uncinate process of the cervical vertebrae. Okay, so these are the important areas we have to know. Here lies the pedicles and here lies the transverse processes. Here lies the transverse processes. So whenever we are doing any procedure from the anterior side, we should be careful to avoid this area. Either go oblique, so go and touch here and then go inside so that you can avoid the vertebral artery, or do the procedure from the posterior side. Remember, only two procedures. One is the stellate ganglion block at the level of the C6, we go here, and for the DRG radio frequency, we go here. Otherwise, most of the procedures is done from the posterior side. And stellate definitely will be going here, but slightly anterior. In stellate, we go anterior to the longus colli muscle. Okay. So these are the important structures that you see in the anterior in posterior image. Now in the lateral view, we can see the vertebral bodies, we can see the disc spaces, we can see the facet joints, we can see the articulating surfaces posteriorly, we can see the area of the spinal canal. So without wasting words, let us go to this area. Okay. So this is the lateral view of the cervical spine. If you compare with the lumbar spine lateral view, one structure, important structure is missing. Can anyone tell which is this? That cannot be seen in the lateral view, but can be seen in the lateral view of the lumbar spine easily. It's the foramen. Okay. Because in the cervical spine, as I have told, the vertebral bodies is smaller and the articular pillars are larger. And here the vertebral foraminal openings are not directed laterally, which is a difference from the lumbar or thoracic area. It is directed slightly anteriorly and inferiorly. So in exact lateral view, we are not able to see the foramens. So that's the difference. Okay. Now, if you look at these small boxes in the anterior side, so we all know there is nothing special. These are the vertebral bodies. And after the small boxes, we have this blue rhomboid shaped boxes. So what are those? These rhomboid shaped boxes. This blue box, what is this area? Please. Here is also one rhomboid shaped.
Pedicle.
No,
Transverse process.
these are not pedicle, not transverse process.
Lamina.
Superior articular.
No, it is not the lamina.
Superior
So
articular.
look at here.
Facet joints.
See the yes. Okay. So these are the rhomboid shaped.
Superior articular process.
Okay. So these are the facet joints. It is not the superior articular process only. It is having the superior articular process. So here it is a superior articular facet and below it is the inferior articular facet. So it is the articular pillar above which is the superior articular process, below which is the inferior articular process. So where is the transverse process? So transverse process we see actually end on, and we can see some shadow here at this point within the vertebral body here, here, okay, similarly here. So I think we can see these are the end-on views of the transverse process. Not exactly end-on because transverse processes are not exactly lateral. They remain slightly anterior as well, anterior and inferior. So you can see here, these are the transverse process and this shadow usually overlaps. So if you look at from the lateral side, their shadow usually overlaps within the shadow of the vertebral body. Okay, so these are all differences that you have to know, and especially while doing cervical procedures, you have to be very, very careful. Now, I am drawing another box. So let us take a different color and let us take a box here. So what is this structure? This structure.
Lamina.
Lamina.
These are the overlapped lamina of the both sides. And after the lamina, if we clear this side, you will be able to see a J-shaped line. Okay, a J-shaped line. Don't concentrate on the side, because if you reverse it and look from the opposite side, it will be the exact J. Here it is not exact J, it is because it is going to the opposite side. But these are actually known as the J lines, or it is also known as the spinolaminar lines. So last portion that I have not asked to you are the spinous processes. Remember, spinolaminar lines are not exactly J-shaped. In fact, if you look at the spine and look at from posterior side, so within inside, so it is straight, but the bony density is such that under fluoroscopy, it looks like a J line or the spinolaminar line. So these are the important features that you have to know in the lateral view of the spine. I think this part understood clearly, the lateral view of the spine and identifying the structures. So this is the image that I was just told you. So this area is the facetal area. This area marked by the red is the transverse process, and through which the vertebral artery is going to the foramen transversarium. This area is the again the rhomboid shaped facet. These are the facet joints. This area is the lamina and this portion is the spinous process. So here we have to check in the flexion and extension as well. Especially if you are seeing any alignment abnormality, we have to check under flexion and also extension, because what might happen in case of spondylolisthesis, one vertebra may move over other and giving rise to a radicular pain also. Now coming to the foraminal view. As I told, the lateral view, unlike the lumbar area, lateral view is not the foraminal view in the cervical spine. So we have to look at an anterior-inferior oblique view to see the foramen. Okay, so what position of the C-arm is done? First, it is moved towards the from lateral to slightly above in one side. Then it is tilted towards the cranial side to then get this image. Okay, so if you look at how we can get this image, let us take this model, and it is similar to the vision. Under vision, we are not looking like the uh, fluoroscope, but still we are doing the same. So what we are doing, how to see it? So we have to move it slightly like this. So this is what is done in this image. Okay. So that is how this image is taken. So for one-sided foramen, the movement will be like this. For the other sided foramen, the movement again will be different and it will be like this. Okay. So it is not that plain oblique view, you will be able to see the foramen. So now you can see this side of foramen, and now here, so this is from the lateral side. Now you have to go like this, slightly anterior from lateral to slightly anterior and then slightly inferior to see the foramens. Then we'll be able to see clearly the uncinate process. We'll be able to see this area. So that is why whenever we are doing any foraminal procedure close to the foramen, we take this foraminal view. So I think you can understand how close the vertebral artery is, because these are the openings for the vertebral artery. So if accidentally we are doing a procedure and we are accidentally gone directly to this area, we can harm. So what is our way to go under fluoroscopy? First hit that area. So first hit this area. Then you go from here to here so that we can avoid the vertebral artery. Vertebral artery will remain posterior. So with time it will not be difficult, but definitely you should always be careful while doing this type of procedure. So let's be back to the presentation. So here in the oblique view, what we can see more clearly this area. That is, we can see more clearly the uncinate process in all the areas. Okay, we can see the disc and we can see the foramen, and also we can see another structure. Okay, in oblique view. So these teardrop shaped images. So can anyone tell what are those teardrop shaped images?
Acid joint.
Transverse process.
No. Okay, it's a difficult question, but let me explain. So let us.
Articular process.
No, it is not also the articular process. So try to see an image when you're looking like this. Okay. So if it is an image, try to see when you are looking like this. So we are looking like this. So what happens when we are looking like this? The opposite articular pillars. Okay. Sorry, not opposite articular pillars. The opposite lamina, they become end on. Okay, when we are looking like this, say for example from this area you are looking, it is very difficult to demonstrate, you are looking like this. So what will happen, this opposite, this area, okay, this area, they will become end on. So it is basically the opposite lamina. So with time we will understand, but now just know it, and then we'll be with next time when we'll going and we'll be demonstrating under fluoroscopy directly the cervical epidural, we'll show how it becomes end on. Okay, a little bit difficult concept, but it is not that difficult also. Now there are some specialized view. Now it is the open mouth AP view of the C1, C2 for the rotoid process and the lateral masses. This looks like this. So open mouth view can show the lateral masses and the rotoid process clearly for the C1, C2, but nowadays it is not much used, but yes, definitely it is very important. Now coming to the facet joint anatomy. So as I told, cervical facet, unlike lumbar facet, they are mostly horizontal. They are plate-like and it is attaching with the above one. So what happens? The capsular area is much more compared to the lumbar facet. So what happens? Here there are possibilities that the capsular breaks sometimes can be there. Okay. So in case of facet joint arthropathy, that is why in the cervical area we usually do not prefer injecting inside a joint. Rather, in those cases, we prefer going to the median branches and go for a median branch block. So they remain located between the superior and the inferior articular processes. They best visualize in oblique on lateral view, and clinical relevance is definitely the target site for the median branch blocks. So this I have already discussed. So what we are going to see in an X-ray. First of all, A for the alignment. We will check whether the alignment is proper or not. And we'll look the bony alignment by looking at the anterior vertebral line, which is depicted in the green color. We'll be looking at the posterior vertebral line, which is shown in the yellow color. Then we'll be seeing the, what is this line? J line, or we also call the spinolaminal line and the posterior spinous line. So they will be well aligned in a normal spine. So whenever there is a height reduction or sometimes there is an anteroposterior displacement, this alignment will be lost. Then we'll be looking at the vertebral body. We'll be seeing at the cortical outline. We'll be looking about the disc spaces, their equality and height. Sometimes it could happen that one disc space is reduced in height, and also we'll be trying to look at the edges of the soft tissue. Okay, so by which we have to determine the structures. Now coming to the needle trajectory planning. This is important not only for the detection but especially for our procedures. So AP view important to find out the midline approach, and spines are our usual guide unless and until there is scoliosis present. So it gives us an idea where is the midline. Lateral view confirms the depth and also avoids important vertical structure, important vital structures. Oblique view is important for the foramen and contralateral oblique view. Remember, the difference between an oblique view and a contralateral oblique view is technically zero, but only thing is it's the observer. When I am seeing, if I am looking at any specific structure from the opposite side, it will be known as the contralateral oblique view. And when in the same view I am looking the same sided structures, I will be telling it an oblique view. So it is not much different, but definitely CLO view that we'll be discussing again and again multiple times. So I'm not going into the detail of that, but with time we'll definitely able to understand what is the CLO view. Now coming to the avoidance of vascular injury, which is crucial and vital in case of cervical spine. So we should always remember vertebral artery course through the transverse foramina of C1 to C6. Ensure the needle placement, avoiding this important vascular structure. And also carotid, especially if you are doing any procedure from the anterior side. But carotid is being a superficial artery, so it is easy to avoid, because whenever doing your fluoroscopy guided procedure, you can simply do one thing for the fluoroscopy guided procedure. So what we can do, we can actually, if you are doing a fluoroscopy guided procedures, do one thing, just put pressure so that the artery goes to the other side, and in between two fingers you put the needle. So in fluoroscope it is not difficult, and ultrasound you can see it. So neither of them are difficult. Now coming to the understanding MRI, because MRI is very crucial for understanding the cervical lumbar spinal structure. In fact, the X-ray gives a very limited information about the spine, whereas the MRI can give you much more detailed information. So what is the basics of MRI? The basics is that magnetism. So it's a high powered magnetic field and powerful to align the hydrogen nuclei of the body. So when they are charged, they are excited, they emit the radio frequency pulses, and these radio frequency pulses with time they will come down. And when these images, hydrogen ions, will be emitting energy, will be capturing those energies in different time phases. Remember, it is physics, it has nothing to do with medicine, but this is the basics that we'll be putting the body into a very high magnetic imaging so that hydrogen nuclei are aligned, they starts emitting the radio frequency pulses, and this relaxation of atom signal is captured in different time phases in MRI scanner. Then these signals are processed and it is shown as the images, and it is done in a cross-sectional manner. That is what is MRI. Now there are few MRI sequences. So some says that what are those MRI sequences? Are these like X-ray taking from one side we are inverting? The answer is no. Actually, it is the different time phases at which of emission at which the image is the signal is taken and through which the image is generated. So based on this, we have some standard MRI protocols and standard time frames for the MRI. By seeing those, we can get information about a specific structure. For example, the T188 image, where the fat is seen white, fluid is seen black. That means here the urine, CSF, they will be having low signal intensity. They will look black. So this is a T1 weighted image because here we can see the spinal cord, and just by the side of the spinal cord, this is the black structure. So definitely it is supposed to be the CSF, and CSF is black. Similarly, if you look at the subcutaneous tissue, so where it is having subcutaneous fat, fat is looking very, very bright. So this is T1 weighted image. And muscles remains intermediate, so it remains gray. And here this is important for finding the bony structures. Okay. So if there is any bony abnormality, we will go for the evaluation for the T1 weighted image. And also, suppose you can see this vertebra. Now, this vertebra is having a marrow edema or subvertebral compression fracture. So, in T128 image, what happened? It will look more black, especially for the fresh fractures, it will look more black. Okay, so by seeing those, you can try to find out definitely the alignment, the bony abnormality. So, this can be found in the T1 weighted images. Coming to the T2 weighted images. Remember, T2 weighted images are very important, especially for the disc, especially for the soft tissue structures. Now, what structures look what color in T2? Remember, the fluid looks white. Okay, here we can see the fluid is looking white. Okay, muscle remains intermediate or gray in signal. Fat remains white. So here both fluid and fat remains white. So here you can see some white is there. So what is this area? This white part?
Nucleus pulposus.
Yes. Because what happens in the vertebral body, if you look at the disc, so what happens? The outer part, there is the annulus fibrosus. In the middle part, it is the nucleus pulposus. So normal nucleus pulposus is having more water than the annulus fibrosus, so that is looking white. Okay, fat also looks white. So what will happen if there is an edema? So what it will look? Now comes the problem.
More.
Because edema looks white. Now in a fatty tissue, if there is edema, the fat will also be white, the water is also be the white. So that is why we are having this fat suppressed image, that is known as the short tau inversion recovery or STIR image. Here there are some recovery pulses to suppress the fat signal intensity. So the aim is that here only water will remain white. So what will happen? If there is any pathology, inflammation, that will pop up because now the fat is black. So STIR is good as it is suppresses fat and highlights edema. So it is important for seeing the soft tissue acute injuries. Remember, in chronic injury, the picture might change, but in acute injury, we will find the soft tissue edema in this area. Okay. So if you take a very simple way, fat is white in T1. Water is black in T1. T2 fat and water both are white, whereas STIR only water is white. Okay. Here it is same. We are seeing the same structures for the cervical spine. So what is this one? T1 or T2?
T1,
This is
T2.
STIR. Simple. Now coming to the MRI planes. Remember, MRI and CT, both we read in planes. And here we can find out the different planes like axial plane where we can cut like this. Sagittal plane, we can cut like this. Parasagittal plane, it is like this but slightly lateral to the median. And also we can see in the coronal plane as also. Okay, so we can also see in different views. So similarly for every structure, we can see these different planes. So I have already told this is the sagittal plane, and parallel to the plane sagittal plane, it will be the parasagittal plane. Similarly, these are the coronal planes and these are the axial planes. Remember, here for the spine, you can have all the planes, or sometimes all the planes are given, but mostly they give sagittal and parasagittal planes, and the axial planes. These are most important for those areas. Now coming to the importance of these planes, I think this part I have already discussed, so no point to going to again. So this is what we can see in the sagittal plane and parasagittal plane. Usually in the MRI, it is given from right to left. So if you look at the first plate, it is the rightmost, and then if you follow, it is, there is no specific rule, but as a convention it is given in a right to left pattern. So if you are seeing a foraminal stenosis in an MRI which is starting early, it is expected to be a right-sided foraminal compression or foraminal pathology. Similarly, this is the central area. Here we can see sometimes it might happen. The disc bulge is not central, it is a paramedian. So we have to go for the paramedian slices. Now coming to the axial view helps to figure out the cord, the disc, the foramens, the facet joints. So everything can be seen under this view. Okay. So axial view and the median sagittal and parasagittal views are very, very important. Rest of the things definitely we'll learn with time. When we'll see patient, we'll see multiple MRIs, because MRI, ECG, XCT, these are not such things that you can only learn by reading. Reading is important, but what is more important is seeing regular patients and regular images. Now coming to the advantage and disadvantages of MRI. So radiation, here there is no ionizing radiation which is there in the X-ray. It is not there. Soft tissue contrast, definitely it is superior for the brain, spine, joint, ligaments. That is why we use more for the soft tissue evaluation. We, from the X-ray images, X-ray and CT, we prefer the MRI. Imaging in planes, definitely MRI is superior, though CT can also show image in planes, and especially for the bony structure, you can get an alternative of the MRI as well. Safety, as it is non-invasive and as well as non-ionic radiation, so it is considered to be safe. Application, it is ideal for the soft tissue abnormalities, tumor, inflammation. Artifacts might be there, but the minimal distortion with the proper technique, patient comfort. Here CT scan or the X-ray wins a little over the MRI, because in a number of patients, the patients might have claustrophobia, and it is very difficult to for those patients to undergo MRI. In fact, for my some of the patients in my initial days, I have to give anesthesia to do an MRI done. But nowadays, it is usually not required, because at least in Kolkata, there are two places where open MRI is available, which is having a comparatively larger bore. So patients usually do not undergo claustrophobia. Now coming to the how to read cervical spine MRI. Okay, so let us go for a step-by-step guide what to look at. First of all, we'll be looking the planes, we'll be looking at the levels, we'll be looking at the sequences, and we'll be looking at the soft tissue, and we'll be trying to rule out the inflammation. Okay, so for the T1 weighted imaging, optimal for assessing the bone anatomy and marropathology. So start from the skull base, try to examine the vertebra from here. So here you can see the dents of the C2, and here you can see the C1 as well. So the structures are much more clear. Remember, in ultrasound you have to know a completely different anatomy, that is a cross-sectional anatomy, but which is not required for the MRI, because here is also it's a cross-sectional anatomy, but it is much real like, much anatomy like, to understanding is much easier. And here what you see at the skull base, examine the vertebra down at the visible thoracic line, look for the alignment, look for the fracture, look for the lesions or marrow abnormalities, and also look at the craniocervical junctions as well. And here in the T1 weighted imaging, apart from the alignment check, you can also check the disc height, evaluate the facet joints for the subluxation or dislocation. Now coming to the T2 weighted image. So what you are looking at the T2 weighted image, here the purpose is to find out the fluid filled spaces or the areas which is having the pathology. Check for the spinal cord signal. If you see some whitish areas within this, what could be the possibility?
Some tumors, mass.
Cystic tumors might be there, but more commonly the myelopathy we more commonly found, or syringomyelia. So that could be whitish within the vertebral body. Then there could be neoplasms. There could be radiation-related changes. There could be trauma or demyelination. There could be the compression effect. So everything can be seen under the T2 weighted image. Now STIR image, it is useful for finding the areas with high water content, like hypertense areas. It is seen in the bone marrow edema, which can suggest the tumor or fracture. It can show ligamentar hyperintensity, which could be ligamentous injury or ligamentous fracture, and also the cord abnormalities. As it is suppressing the fat, this can actually show the real edema inside the cord as well. Axial imaging helps to give you a cross-sectional view. It is useful for inspecting the spinal canal for epidural abnormalities such as hemangioma or abscesses, stenosis from the bony and soft tissue, and any structure which is compressing the cord. So if the disc is coming and this is compressing at the central level, so you can see it is compressing the spinal cord. If it is going to this area, it is compressing on the lateral canal, it is compressing on the cord. Or if some bony structure or this from this area, the facetal area, some structure is protruded and it is compressing the exiting nerve root, then it is also, we can see it is a area where it is being compressed. Okay, so this type of pathologies can be seen easily with the axial imaging. Okay, now coming to the stepwise approach pattern. So start with the bones from the T1 imaging, check for the fracture, lesions, alignment, pay particular attention to any abnormal mallow signals or the suspicious bony overgrowth, assess alignment similar with the X-ray. Then coming to the disc spaces, check under T2, so disc dehydration by looking at the whiteness or signal at the disc, or disc degeneration, bulging or herniated disc can be examined with the T2 image, and then focus on the spinal canal and the cord and look at for the cord signal changes, and also check for the STIR event, especially for the ligaments and the bony defect, and if there is any stenosis, you have to look for that as well and document at the specific level the possible causes, whether it is coming from the you are suspecting it is coming from the osteophytes or herniated disc, etc. So what are the common pathologies and red flags? So epidural hemorrhage appears as a mixed signal intensity and collection in both T1 and T2 image, and it can cause cord displacement requiring urgent surgical correction. Cervical stenosis or myelopathy. So stenosis is basically the narrowing of the canal. It may be due to disc protrusion, it may be due to osteophyte, and look at the cord signal intensity and T2 or STIR to see the myelopathy present or not. Infectious pathologies like epidural abscesses may appear as an enhancing collection of the post-contrast. Especially what happens when there is a very active tissue like an infectious tissue, what will happen? In that case, you can order a contrast enhanced MRI. So contrast enhanced MRI will take it more this radio contrast it will take. So in that case, the abscesses will be much more clear. Then check for the adjacent bony changes and the paravertebral soft tissue swelling. For the trauma related issues, look at for the fracture, look at for the ligament injuries and evaluate the facets for subluxation or dislocation. In neoplasm, tumors can appear as a focal marrow hyperintensity on T1 or STIR. Look for the associated soft tissue masses and the canal compromise. Okay. So common causes of the foraminal compromise is spinal spine. So one could be the disc herniation, uncovertebral joint osteophyte, or sometimes facet arthropathy causing and compressing over it. Disc herniation, it is how it looks. So here the disc herniation is comparatively larger and also compressing over the cord. So now it is not always every time it will be compressing over the cord, but in a number of cases, if the herniation is more, it can compress over the cord as well. Now, herniation can be median, which remains at the center. It could be paramedian, it could be lateral or foraminal, or it could be extraforaminal as well. Okay, so this type of which type? So what will happen if it is a central prolapse and indenting on the thecal sac, not indenting on the cord? So what will happen? Usually the symptoms are minimal. Usually the symptoms occur as a discogenic pain. That means the pain originating from the disc, but it is not compressing over any nerve. For the paramedian compressions, the chances of going into the radiculopathy is more, and definitely for the foraminal, it is much more. Now, here we can see the central or midline herniation, where you can see exactly from the midline, this is a midline or this type of herniation. So, in mild cases, it will not present, it will mostly remain asymptomatic or sometimes present as a discogenic pain. In moderate cases, it can cause sometimes compression of the cord associated with the myelopathy, which includes weakness, difficulty in walking, and loss of fine motor control. Okay. Now, in the paracentral herniation, when it is coming close to the disc, it may compress the spinal cord or adjacent nerve root. Then symptoms related to the exact which nerve root is compressed. In the last day, we have discussed how the C5 radiculopathy present, how the C6 present, C7 present. So, depending on at which level it is affected, the symptoms will be like this. So, most commonly affected areas are the C5, C6 and C6, C7. So, ultimately, you will be getting a area of the C6 or C7 area will be affected in those cases, and foraminal herniation primarily affects the single nerve because here it is not compressing over the cord, so will be affecting mostly the exiting nerve root, and the symptoms include the unilateral arm pain, numbness or weakness corresponding to the affected nerve root. Okay, and the types of herniation. So initial herniation phase, it remains as a bulge. So how this bulge is formed, we all know that this nucleus pulposus and this annulus fibrosus are there. Annulus fibrosus are made of collagen, and there are crisscross pattern collagen of 16 to 25 sheets are there. So when the sheet starts breaking from inside, what will happen? It is like a balloon. So there is pressure inside, so it will push the outer skin of the balloon outside and it will be presented as a bulge. Then the bulge progresses, then it becomes a disc protrusion. Then when the material comes out, it becomes an extruded disc. Then it becomes the uncontent. Till this area, it is content. That means the outermost shell is remaining intact. So it is a content extrusion. Now it will be uncontent. Now what happens from this area? It is only the mechanical compression, and within the disc whatever pain is happening because of the changes within the disc it is happening. But as it becomes uncontent disc, then what will happen? This soft tissue or this nucleus pulposus, they will come out, and Your nucleus pulposus is highly immunogenic, so it causes inflammation. Remember, this nucleus pulposus is something that is not regularly come in contact with the blood. So when they are coming at this area, they produces a strong inflammation, and that can cause severe pain. Similarly, when the connectivity with the inside nucleus pulposus is lost, it is called a sequestrated disc or disc sequestration. And this condition is known as a pseudo herniation. It happens when actually disc is not herniated, but as there is a displacement or spondylolisthesis, it is also giving a picture of the disc protrusion like phase, and it can also compress over the nerve root, and that can cause also a radicular pain. Now coming to the degenerative disc disease. So degenerative disc disease is an early stage. So from here I started with the disc bulge. But even before that, even before the disc becomes bulged, being a contact outer contour, the pain can also start. Remember how it can start? The outer shell of the disc is not having any pain sensitive structures. So only the outer third is having the pain sensitive structures. The inner third of the annulus, the innermost third and middle third of the annulus do not have any pain sensitive structures. But when this area is degenerated, along with the angiogenesis, some small nerve fiber upregulation also takes place. And then what happens? This area becomes either chemically sensitive or mechanically sensitive. So with discography, we'll discuss this chemically sensitive and mechanically sensitive, what are those. But remember what happens, will be upregulation of the pain receptors, and now whenever there is a pressure over the disc, it will cause pain. So disc will become more painful, and in this condition it will cause a pain. So this pain is much different from a radicular pain. The pain will not be radiated along the nerve root because there is no nerve root compression, but the pain will be remaining at the back. It will remain a poorly localizing pain, and it is mainly traversed by the glera communicants and also through the sinovertebral nerves, and this type of pain is known as the discogenic back pain. In discogenic back pain, you will see the typical appearance of the disc, that is, will be absent. That means the whitish appearance that you have seen in a normal disc will be absent because the disc become dehydrated, and also there could be end plate changes seen, especially modic type 2 end plate change, and also sometimes some hyperintense points can be seen. Okay, so this is what is known as the degenerative disc disease. So these are the basics of the changes that we see in the X-ray and MRI. And in the next class, we'll be discussing further on the cervical pain. So any questions in this part? Okay, no questions, then let us go for the MCQ. So switch on the okay, so let us start playing quiz.com first.
Anyway, sound. Nidhi,
So let's start.
Quiz.com, KSGE, Dr. Hyena
The
joined.
bifid spinous process is typically found in which cervical vertebrae? C2 C6. The transverse foramina of the cervical spine transmit which structure?
Dr. Payne joined.
Vertebral artery. The third occipital nerve originates from? Posterior root of C3. The uncovertebral joints are formed by? Uncinate processes.
Kaushik Kanakaraj joined.
Which imaging modality offers the best soft tissue contrast in cervical spine evaluation? MRI. On a T2 weighted MRI image, CSF appears. White. Which view is best to visualize the odontoid process? Open mouth AP view. Which muscle originates from the transverse processes of C1 C4? Levator scapulae.
Final question. Double points.
The cervical facet joints are innervated by? Medial branches of posterior rami.
Third place. JJ. second place, Bharif Narayanan. And the winner is Indu M.
Who is Indu M? Hello.
Hello, sir.
Okay, congratulations. Okay, you played with your own name, so that's a great thing because we do not ask anyone to play there with their own name because someone is doing very wrong, so he should not be feel depressed. That is the only reason behind. But thank you for playing in your own name. Okay, so
Thank you,
let's
sir.
for today, and this recording will be posted tomorrow, and also check the study materials which has been posted. Okay, so let's say bye bye for today.
Good night.